Hello, I'm Lieutenant Nick Stauffer, and it's my pleasure to share this presentation with you on the pharmacist's role in HIV care, Perspectives from Practice. Before I begin, I'm required to give this disclaimer that this presentation was prepared and is being given in my own personal capacity. The opinions and information expressed in this presentation are my own and do not necessarily reflect the view of the Indian Health Service, the U.S. Public Health Service, or the U.S. government. Just some background information about me and where I practice before I get into the main content of the presentation. I graduated from Wilkes in 2017 and then commissioned in the U.S. Public Health Service. I completed my PGY1 residency at Gallup Indian Medical Center in 2018, and I have been stationed at GIMC since that time. I'm a clinical pharmacist and serve as the clinic manager of the pharmacy-based Special Infectious Diseases, or RxID, program, and I'm also the PGY1 residency preceptor for the RxID and clinical informatics rotations at GIMC. When I'm not in clinic or precepting, I also work as a clinical pharmacist in our emergency department, as well as inpatient acute care. The photo here is a picture of me and my lovely fiancée Amanda. This is Gallup Indian Medical Center, which is located in the high desert environment of Gallup, New Mexico. On the left is our main hospital building, and on the top right is our outpatient clinics and doctor's offices building. GIMC is part of the Indian Health Service, and so it basically functions like an accountable care organization, or ACO, providing a fully integrated system of healthcare services and insurance coverage similar to VA or Geisinger Health System, but specifically for underserved Native Americans. GIMC is the largest and busiest federally run IHS facility. Gallup is surrounded by the Navajo Nation, and our facility is the area referral hospital and medical center. We have a Level 3 Trauma Center emergency department with about 24 beds divided into 2 wings, as well as several trauma and advanced life support resuscitation bays. We also have a full inpatient service with approximately 96 beds, consisting of a surgical suite with several operating rooms, med-surg and specialized COVID wards, a 6-bed intensive care unit, a pediatrics ward, and a labor and delivery women's health unit. As a medical center, we also have on-site outpatient clinics, doctor's offices, dental, and optometry services. We have a PGY1 pharmacy residency program that accepts 2 residents annually, and we also host a multitude of students from several pharmacy schools for our ambulatory care API. Our facility is unique in that it offers many clinical practice opportunities for pharmacists in our pharmacy-based ambulatory care clinics, and our clinical pharmacists do have prescriptive authority within their clinics via extensive collaborative practice agreements. As I mentioned, I'm the lead for our RxID program, which has a team of 5 clinical pharmacy specialists and focuses on HIV, PrEP, PEP, hepatitis B, hepatitis C, sexually transmitted infections, and tuberculosis. The RxID program currently manages a panel of a little over 200 patients. If you're interested in ambulatory care, our facility has a lot of unique opportunities, and I would encourage you to look into our API and consider applying to our residency program. And please feel free to reach out to me with any questions that you might have about our program. Okay, so what do I want you to get out of this presentation? Well, you've already had some of the pharmacology and therapeutics of HIV, so I'm going to focus on clinical pearls and application of that knowledge in practice. By the end of this presentation, you should be able to describe the pharmacist's role in HIV care. I'm also going to try to promote important pharmacy skills that will be generally applicable to your practice as you move forward through future PT modules and rotations by emphasizing the holistic, patient-centered approach to care, and making sure that you are aware of how to locate and use HIV guidelines and drug information resources, which is much more important than getting caught up in trying to memorize all the detailed nuances of HIV. However, there are some details that you will just have to have memorized for the NAPLEX, and I'll point these out to you along the way. Another important but generally applicable skill that we'll focus on is accurately using and interpreting CDC vaccine schedules to formulate appropriate immunization recommendations. Finally, we will learn how to evaluate antiretroviral therapy so that you will have the tools you need to provide safe and effective care to people with HIV, no matter what your future practice setting might be. We'll start by discussing the pharmacist's role in HIV care. Now, I know what most of you are probably thinking. I'm not planning on being an HIV clinical specialist, so how is this information relevant to me? Why do I need to know this? I remember feeling frustrated as I was sitting in the PIC with my friends studying for the HIV PT test and sharing that exact sentiment myself. I didn't realize it when I was a student, but the truth is that whether clinical or non clinical, all pharmacists have a role in HIV care. Whether you work in ambulatory care, community pharmacy, or inpatient, you are a multidisciplinary team member whose role is to ensure that all drug therapy will be safe and effective. Don't be intimidated by HIV because you do not need to know everything. You just need to be aware of what you don't know so that when you see something unusual, it will trigger you to slow down and take a closer look, even if you don't remember the details. Evidence-based medicine is always progressing as new science directs guideline changes, so what you are learning now may very well be obsolete in a few years anyway. That's why knowing where to look up information and get help if needed is much more important than having all of the details memorized. One of the most important but frequently overlooked roles that pharmacists have in HIV care is promoting sexual and public health. HIV is a global pandemic and national epidemic, but it is within our power to end it. At the direction of the President and Surgeon General, the Department of Health and Human Services have developed a plan for ending this epidemic in the United States. This plan focuses on treatment as prevention, also known as TSP, that involves screening and treating as many people as possible to prevent HIV transmission. For this reason, you should be familiar with the over-the-counter or a quick in-home HIV test, since patients may ask community pharmacists about this test, and you should stock this test in your community pharmacy. Congruent with this plan, pharmacists should also recommend multifactorial risk reduction strategies, such as promoting condom use, encouraging patients to discuss HIV status with their partners, promoting PrEP, needle exchange programs or proper needle sterilization techniques, and encouraging patients to know their own HIV status, since the plan recommends that all adults get tested for HIV at least once in their lives, and more frequently if they are at an increased risk of contracting HIV. Another key part of the plan to end the HIV epidemic is decreasing the stigma associated with HIV. Really, this is a human rights issue, since time and time again, people with HIV experience unfair discrimination in society. Pharmacists should help empower people with HIV, since the evidence is very clear that undetectable equals untransmittable, or U equals U. In other words, a person living with HIV who is on treatment and has an undetectable viral load cannot transmit HIV to their sexual partners. This is not the 1980s or 90s anymore, and excellent treatment options exist that enable people with HIV to have a quality of life and life expectancy nearly identical to those of individuals who do not have HIV. Advances in antiretroviral pharmacotherapy have enabled HIV to be manageable, just like any other chronic disease, and I tell my newly diagnosed patients this all the time. If you have high blood pressure, you take a pill every day. If you have diabetes, you take pills and maybe even inject insulin multiple times per day. HIV is no different. If you have HIV, you usually just take one pill once a day, and if you do, then you don't have to worry about spreading HIV to others, and you can just go about your life. Getting this message out and decreasing the stigma associated with HIV are key to ending the epidemic. Even something as simple as having some informational posters or flyers hanging in your pharmacy can help promote a welcoming environment and a safe space where patients will feel comfortable opening up and discussing these topics with you. Another aspect of the pharmacist's role is linking patients to care, as well as facilitating transitions of care. Encourage your patients to get screened for HIV, possibly with the OraQuick OTC test that you should stock at your pharmacy. You should also build connections within your community so that if a patient comes back to you saying that their test showed a preliminary positive, you know where to refer them to confirm the diagnosis and get them started on antiretroviral therapy. It is also important to know where to refer patients who are interested in PrEP and to help them enroll in the Ready Set PrEP program, which can cover the cost of PrEP for patients without insurance. Patients who present to the pharmacy for emergency contraception are potentially at risk of HIV exposure as well, and they may benefit from consultation and referral for HIV and STI testing services or even HIV post-exposure prophylaxis, depending on their situation. Make sure that you keep time-sensitive PrEP and PEP medications in stock at your pharmacy. Facilitating medication reconciliation associated with transitions of care is another important role that pharmacists will play, especially if your pharmacy provides services to a long-term care facility. As I mentioned, Ready Set PrEP is a really helpful tool, and your pharmacy can participate. The program can help connect people to HIV testing services and to providers who can prescribe PrEP. Patients can get a coupon card that your pharmacy can bill, and it enables them to receive PrEP at no cost. Of course, a final aspect of the pharmacist's role in HIV care is ensuring safe and effective therapy. We can do this by promoting health maintenance, such as recommending indicated vaccines. The figure on the top right is one of the CDC immunization schedules for people with HIV, and we will revisit this key intervention later in the presentation. Promoting healthy diet and exercise are additional ways that pharmacists can promote health maintenance. Promoting adherence and reducing barriers to adherence, such as optimizing drug therapy to reduce pill burden, offering specialized packaging such as blister packs, pill boxes, or customized medication strips, can make a big impact for patients who just need a little extra help managing their medications. Recommending smartphone apps, or even something as simple as a calendar and alarm clock, can help patients better remember to take their medications. Other factors, such as substance use and mental health, can also have a negative effect on adherence, so screening and offering resources for these conditions can have a big impact as well. The main way that pharmacists can ensure safe and effective drug therapy is by performing a prospective drug review, which should be performed whenever initiating, changing, or discontinuing any component of antiretroviral therapy, including treatment, PrEP, and PEP, as well as any concomitant medications for comorbid conditions. When assessing a proposed ART regimen, one should determine if the regimen is complete, optimized, and if appropriate follow-up is in place. A helpful tool to assist in performing the prospective drug review is the I-Escaped CPR mnemonic, which should hopefully sound familiar to you. The I-Escaped CPR mnemonic, spelled out here, will help ensure that you perform a complete and accurate prospective drug review. Let's look at each of these components of the prospective drug review in the context of antiretroviral therapy, starting with interactions. There are many interactions to be aware of when evaluating antiretroviral therapy, whether these are other antiretroviral agents, non-ARV drugs, over-the-counter products, or even food. Some of these interactions are intentional, as is the case with the pharmacokinetic enhancers cobikistat and ritonavir, which are used to increase the levels of protease inhibitors and elvitegravir to therapeutic levels. Other drug interactions may result in subtherapeutic or toxic levels of either the ARV being used or the other drug. Interactions can generally be classified as affecting absorption, metabolism, or excretion. Interactions affecting distribution, the other pharmacokinetic phase, can happen if a drug causes significant displacement of ARVs bound to plasma proteins, but this is not very well studied and not thought to be clinically significant. Although not caused by drug interactions, other situations, such as pregnancy or hypoalbuminemia, can also affect the volume of distribution of certain antiretroviral drugs, and this effect may be clinically significant and require a dose adjustment, depending on which ARV is used. Let's start with the interactions affecting absorption. Throughout the presentation, any information highlighted by these blue NAPLEX topic boxes are things that you should know for the NAPLEX. Some ARVs, mostly the non-nucleoside reverse transcriptase inhibitors, or NNRTIs, are sensitive to an acidic environment for absorption and will be affected by acid-reducing agents, such as histamine 2 receptor antagonists and proton pump inhibitors. In the case of rilpivirine, which must be taken with a fat and protein-containing meal of at least 500 kilocalories, concomitant proton pump inhibitor use is an absolute contraindication, and other acid-reducing agents must be separated, preferably by at least 6 to 12 hours. On the other hand, efavirenz, another NNRTI, should be taken fasting at bedtime to prevent overabsorption and increased side effects. Another group of interactions that affect absorption are the binding interactions by polyvalent cations, which primarily affect the integrase inhibitors. Knowing how to counsel patients to take their medications to mitigate binding interactions is a very important but commonly misunderstood topic. As an example, instruct the patient to take dolutegravir first. Then they must wait 2 hours before taking polyvalent cations to allow the dolutegravir to be absorbed and not bound up by the polyvalent cations. Alternatively, if patients take polyvalent cations first, they must wait a full 6 hours before taking dolutegravir. This is to ensure that the polyvalent cations, which are poorly absorbed in the gut, move far enough along the GI tract so that they will not bind to the dolutegravir. It is important to use appropriate health literacy when explaining this to patients. So I tell my patients, if they take dolutegravir and vitamins at the same time, the vitamins will bind up the dolutegravir and they're just going to poop it out and it won't work. The final group of absorption-related interactions are those involving P-glycoprotein, or PGP, which is an efflux transporter in the gut. Agents that inhibit PGP, such as the protease inhibitors, result in increased absorption due to decreased efflux. Metabolism-related interactions are predominantly mediated by the cytochrome P450 isoenzyme system. These are frequently encountered and clinically important drug interactions, so don't be surprised to see these on the NAPLEX. Protease inhibitors and cobikistat are both CYP450 3A4 inhibitors and substrates. Other classes or drugs may be substrates and or inhibitors or inducers. A common example of this interaction is statins with protease inhibitors and pharmacokinetic enhancers. Some statins, like simvastatin, are contraindicated, while others, such as atorvastatin and rosuvastatin, are dose-limited. Rilpivirine, an NNRTI, is also a CYP3A4 substrate, and concomitant administration with CYP3A4 inducers is contraindicated per the product labeling. Specific CYP3A4 inhibitors to be aware of that may not be used in combination with rilpivirine include the anticonvulsants carbamazepine, oxcarbazepine, phenobarbital, and phenytoin, the antimycobacterials rifampin and rifapentine, St. John's wort, and more than a single dose of systemic dexamethasone. Another set of metabolism-related interactions are those mediated by the uridine diphosphate glucuranosyl transferase 1A1 enzyme, also known as UGT1A1 or UDP-GT1A1. This set of interactions primarily affects the integrase inhibitors, which are substrates of UGT1A1. Other drugs, particularly some anti-epileptic drugs, antibiotics, and certain other ARVs, may either be UGT1A1 inducers or inhibitors. A clinically significant example of this interaction is rifampin, which is used to treat tuberculosis, when it's used with dolutegravir. Because rifampin is a UGT1A1 inducer, the dose of dolutegravir must be increased to twice daily when these two drugs are used together. A final set of drug interactions are those affecting excretion. The most common example of this is the combination of dolutegravir and metformin, which causes decreased renal excretion of metformin, resulting in an increased risk of lactic acidosis. For this reason, metformin must be limited to 1,000 milligrams daily when used in combination with dolutegravir. For patients with renal impairment, an even more cautious approach should be used. With so many drug interactions affecting the antiretroviral agents, thankfully the University of Liverpool offers a free HIV-specific drug interaction checker website and mobile app. Unlike traditional drug information resources like Micromedics or Lexicomp, their drug interaction database is updated daily and has very detailed information about each drug interaction with literature, citations, and data from relevant pharmacokinetic studies. This resource is a great tool for you to bookmark just in case you ever need it, and it should be the first place you go to check for antiretroviral drug interactions. However, this tool does not include every single drug in existence, and of course, it never hurts to verify information with a second source, so feel free to use your preferred drug information resource as a double check. The next step in the prospective drug review using the I-escaped CPR mnemonic is efficacy. When evaluating antiretroviral therapy for efficacy, the first question you should ask is this a complete regimen? Typically, a complete regimen will include 2 functionally distinct nucleoside reverse transcriptase inhibitors plus something else. As you can see in the figure, The molecular structures of lamivudine and emtricitabine are so similar they can almost be considered the same drug, and so these two NRTIs should never be used together. The other component, sometimes called the backbone of the regimen, is typically an integrase inhibitor these days, but it could also be a boosted protease inhibitor or a non-nucleoside reverse transcriptase inhibitor. There are a few exceptions to this rule for what is considered a complete regimen. The guidelines state that Dovato, a two-drug single-tablet regimen containing dolutegravir and lamivudine, may be considered for initial antiretroviral therapy in certain patients. We will take a closer look at guideline-recommended initial antiretroviral therapy later in the presentation. The other two exceptions to the rule can only be considered for patients who are already on antiretroviral therapy and have an undetectable viral load on a different regimen. Switching regimens in this case is typically done to decrease pill burden or reduce side effects. These two exceptions are Cabenuva, which is a commercially available package that contains two separate injections of cabotegravir and rilpivirine. These extended-release injectable suspensions must be administered intramuscularly once monthly in clinic. Patients may not self-administer these injections. Before starting Cabenuva, patients must take these same drugs orally for 28 days to ensure tolerability. A final exception to the rule is the two-drug combination of dolutegravir and rilpivirine, which is commercially available as the single-tablet regimen Juluca. Another consideration when evaluating antiretroviral therapy for efficacy is if the virus exhibits any clinically significant genotypic mutations that result in resistance. Some mutations decrease susceptibility to one class of antiretroviral drugs while increasing susceptibility to another class. Stanford University maintains an excellent database of known HIV drug resistance mutations, which is very helpful for maximizing efficacy of antiretroviral therapy in patients who have resistance mutations. Although you will not be expected to know how to use this database, I wanted to at least mention it so that it would sound familiar to you if the topic ever comes up for discussion in your future practice. You will not be expected to have specific resistance mutations memorized for the test, but if a patient case question tells you that the patient's virus is resistant to a particular class of antiretroviral drug, be sure to avoid that class of drug when selecting your answer. Next up in the I escaped CPR mnemonic is checking for side effects. As pharmacists, get into the habit of assuming that any new problem that the patient has is drug-related until proven otherwise. You may remember learning about the Naranjo nomogram, which is a tool that can be used to determine the probability that a problem is caused by a drug or other factors. If a patient experiences side effect from their antiretroviral therapy, or even if they think some problem that they are experiencing is caused by their antiretroviral therapy, it could negatively affect adherence. I have to say from experience, this is way more common than one might expect, particularly among patients with low health literacy. However, I've also seen plenty of instances where a patient is experiencing adverse effects caused by a drug, so it is important to be vigilant for common class-related adverse effects. For example, NRTIs can cause mitochondrial toxicity, resulting in myopathy, neuropathy, fatigue, and/or lactic acidosis. If a patient experiences NRTI toxicity, we could change them to an NRTI-sparing regimen to alleviate these adverse effects. Abacavir has the additional adverse effect of increasing cardiovascular disease risk. Common side effects associated with the NNRTIs include hepatotoxicity, gastrointestinal upset, and central nervous system effects such as weird dreams, depression, or even suicidal ideation. Common adverse effects associated with the integrase inhibitors are metabolic in nature, such as causing weight gain or impaired glycemic control. Protease inhibitors, like the NNRTIs, can also cause hepatotoxicity and GI upset, as well as lipodystrophy, dyslipidemia, and impaired glycemic control. The next component of the prospective drug review is assessing for contraindications, and there are several that you should be aware of. The first group of contraindications are those concerned with baseline viremia and baseline CD4 count. Starting Dovato is contraindicated if the viral load is greater than 500,000 copies per milliliter. Starting rilpivirine is contraindicated when the viral load is greater than 100,000 copies per milliliter. Finally, starting nevirapine is contraindicated when initial CD4 count is greater than 400 cells per microliter in males or greater than 250 cells per microliter in females, although this drug is not commonly used first line anymore. The next contraindication to be aware of is concerned with patients who are co-infected with chronic hepatitis B, and you should be very cautious when changing ARVs in these patients. Chronic hepatitis B requires lifelong treatment with 2 agents that are active against hepatitis B. Some agents that are used to treat HIV are also used to treat hepatitis B, and these drugs contain black box warnings that stopping hepatitis B therapy could cause an HBV flare and kill your patient within 6 months due to fulminant liver failure. Make sure that patients who have HIV and hepatitis B are on a regimen that contains 2 of the following drugs: tenofovir, either lamivudine or emtricitabine, since they cannot both be used together, or entecavir. Although not an absolute contraindication, abacavir is not recommended for use in patients who have pre-existing or are at increased risk for cardiovascular disease. Before starting HIV pre-exposure prophylaxis, make sure that the patient has a documented negative HIV test within 1 week of initiating PrEP. Patients also need repeat HIV testing and a confirmed negative test every 3 months while they're taking PrEP. To prevent confusion or accidentally filling PrEP without the required testing, I recommend that you put for PrEP in the prescription sig, along with the date when the next HIV test is due. Also, make sure that PrEP prescriptions are processed with no more than 2 refills or a 90-day supply. There are requirements for HIV post-exposure prophylaxis as well. PEP must be initiated within 72 hours of the exposure, and you should also verify the patient's baseline HIV and hepatitis B status before initiation. Finally, be vigilant for the other aspects of the prospective drug review that can result in contraindication. For example, abacavir cannot be used in patients who are positive for the HLA-B star 5701 haplotype due to their increased risk of potentially life-threatening hypersensitivity reaction. And we've already discussed the drug interactions with rilpivirine that result in contraindication. Allergies are next in the iEscape CPR mnemonic, and you should always check for known allergies or hypersensitivity reactions before initiating any drug. Additionally, be aware of pharmacogenomic testing that should be performed to ensure that patients do not have a genetic predisposition to certain adverse drug reactions. We have already discussed the required HLA-B star 5701 testing before starting abacavir. Glucose 6-phosphate dehydrogenase deficiency is a genetic condition that can affect anyone, but individuals of Black or African, Asian, Mediterranean, and Native American ethnicity are at the highest risk, and these individuals should be screened for G6PD deficiency before starting the oxidant drugs dapsone and cotrimoxazole, which could otherwise cause hemolytic anemia in these patients. Pay particular attention to sulfonamide allergy and its potential cross-reactivity, since sulfa allergy is more common in HIV patients than in the general population. Obviously, cotrimoxazole is a sulfa drug, but there is a small chance of cross-reactivity with dapsone and darunavir as well, particularly in patients with severe sulfa allergy. The next part of the iEscape CPR mnemonic is pregnancy. There are special considerations for pregnancy and lactation in patients with HIV. HIV can be transmitted via lactation, and so breastfeeding is not recommended. When considering antiretroviral therapy for pregnant patients, you have to ask, is this a new HIV diagnosis in pregnancy? How far along is the pregnancy? What is the expectant mother's viral load? Is the patient already on antiretroviral therapy? Was this a planned pregnancy? An unplanned pregnancy? There are varying levels of intrapartum and postpartum prophylaxis or presumptive treatment required for the baby based on the baby's risk level, which is determined by these factors. The perinatal HIV guidelines, which can be found at clinicalinfo.hiv.gov, are a helpful resource for managing these complex patients. Clearly, pregnancy considerations are one of the more complicated aspects of HIV care. If you need help managing a complex pregnant HIV patient, the UCSF Warm Line can assist by providing free expert consultation to clinicians. The National Clinician Consultation Center also provides consultation for complicated cases regarding general HIV or AIDS questions, hepatitis C, substance use, PrEP, and PEP. Achieving viral suppression as early as possible during pregnancy will result in the best patient outcomes and substantially decrease the risk of vertical transmission of the virus to the baby. For newly diagnosed acute HIV in pregnancy, dolutegravir in combination with two suitable NRTIs is the only preferred initial ART regimen, and this regimen is preferred for pregnant patients previously diagnosed with HIV as well. Example regimens include the single tablet regimen Triumec, which contains dolutegravir, abacavir, and lamivudine, or the combination of Tivicay, which is dolutegravir, plus either Truvada or Descovy, which are co-formulated products containing emtricitabine and either tenofovir disoproxil fumarate or tenofovir alafenamide fumarate, which is more commonly just referred to as tenofovir alafenamide. Although you are not expected to be familiar with the specific regimens used for children born to HIV-positive mothers, remember that all neonates require prophylaxis or presumptive treatment within 6 hours of birth, and that the regimen is selected according to the baby's risk level. Again, knowing where to find this information and where to get help if needed is more important than having the specific details memorized. The next consideration during the prospective drug review is elimination. Always assess the patient's renal function and be aware of the differences between the Cockcroft-Gault creatinine clearance and the estimated GFR, which is calculated using the MDRD study equation. We will revisit this point later in the presentation. Hepatic function should also be assessed. The transaminases are frequently used to evaluate hepatic function. Some facilities, namely IHS and VA, sometimes still use the old nomenclature for AST and ALT in their electronic health records, which are SGOT and SGPT, respectively. Use the cheeky phrase, "You got asked by your preceptor which one was which and you didn't know, but now you do," to help you remember them. While the transaminases are informative, for example, an AST-ALT ratio of 2 to 1 suggests alcohol use, they do not tell the whole picture and are frequently misunderstood. Although elevated transaminases indicate that the liver is in an inflamed state, working hard to metabolize substances that may be hepatotoxic, the fact that these enzymes are elevated means that the liver is compensating for this. In patients with severe hepatic impairment, the AST and ALT may appear normal or even low because the damaged liver is not able to produce adequate quantities of these enzymes. The synthetic liver function tests, including total bilirubin, albumin, platelets, and INR, can provide a more complete picture of liver function, and these tests are used in several calculated indexes for hepatic function, including the APRI score, which is used to predict fibrosis, and the Child-Turcotte-Pugh score, which should only be considered if the patient actually has cirrhosis. Additionally, patients should be screened for viral hepatitis. Next, evaluate the dose for appropriateness. Be mindful of any dose adjustments that may be required in the case of renal or hepatic dysfunction, changes in the volume of distribution due to pregnancy, or a drug interaction. The next part of the iEscape CPR assessment is concerned with compliance or adherence. Medications only work if patients take them, so assessing and removing barriers to adherence is extremely important and should be assessed at each visit. Promote adherence by making sure that the regimen is optimized, by decreasing pill burden with a single tablet regimen if possible, and working to minimize adverse effects. Look for and address any barriers to adherence that may exist, such as substance use, behavioral health concerns, a lack of family or social support, cognitive impairment, and financial considerations. Sometimes patients are not adherent because they get caught up in the busyness of day-to-day life and forget to take their medications. Encourage patients to get into a daily routine, such as taking their medications with their daily coffee in the morning, or when they brush their teeth in the evening before bedtime. Smartphone apps or even a simple alarm clock and calendar can prompt patients and help them keep track of taking their medications. Specialized packaging such as pill boxes, or if your pharmacy provides medication strip or blister packing services, can also be helpful. Next, assess the purpose for antiretroviral therapy. Is it being used for treatment or prevention? Is the specific agent appropriate for this specific patient? Is it guideline recommended? Is there any required baseline testing, such as for HLA-B star 5701 or initial viral load? For pre-exposure prophylaxis, is the agent contraindicated in this specific patient? Has the required baseline HIV screening been performed and a negative result documented? The PrEP guidelines are a useful resource that can be found at the link shown. For post-exposure prophylaxis, is it indicated based on the required initiation timeline and risk stratification level? Is the selected regimen one that can be used for PEP? Let's take a closer look at pre-exposure prophylaxis, since this is the most common aspect of HIV care that community pharmacists will encounter. The first-line guideline-directed agent for PrEP is emtricitabine tenofovir disoproxil fumarate, also known by the brand name Truvada, although a generic is now available. The dose is 1 tablet by mouth daily, and this drug may be used for PrEP in patients of all genders, and for PrEP due to sex or IV drug use. However, it is not recommended for PrEP if the patient's creatinine clearance is less than 60 milliliters per minute. Some studies have shown the effectiveness of on-demand 2-1-1 dosing of PrEP, but this is not approved by FDA. The new CDC guidelines state that on-demand PrEP may be considered in cisgender men and transgender women if sex is infrequent and can be anticipated, but it is not recommended for most patients. On-demand PrEP cannot be used for PrEP in cisgender women or for PrEP due to IV drug use. The newest agent that is available for PrEP is cabotegravir extended-release injectable suspension, commercially available as Apretude. After an optional 28-day oral lead-in to ensure tolerability, these injections are administered in the clinic once every other month. Apretude may be used for PrEP due to sex in patients of all genders, but it cannot be used for PrEP due to IV drug use. This agent is an exciting development for PrEP, and studies have shown it to be superior to Truvada at preventing sexual transmission of HIV. Co-formulated emtricitabine tenofovir alafenamide, commercially available as Descovy, may also be used for PrEP in certain patients, but it cannot be used for PrEP in cisgender women or for PrEP due to IV drug use. The main reason to use Descovy for PrEP is if patients have renal impairment that prevents the use of Truvada. A final agent that you may hear about that has been studied for PrEP due to IV drug use is tenofovir disoproxil fumarate monotherapy. However, this is not recommended by FDA or CDC and should not be used for PrEP. The first-line regimen for both occupational and non-occupational HIV post-exposure prophylaxis is the combination of dolutegravir 50 mg by mouth daily plus co-formulated emtricitabine and tenofovir disoproxil fumarate 200 mg 300 mg by mouth daily for 28 days. PEP must be started within 72 hours of the exposure, and the patient should have baseline HIV and hepatitis B testing before initiating PEP. It is important to note that Descovy, which is emtricitabine tenofovir alafenamide, cannot be used for PEP. You must use Truvada. Raltegravir 400 mg twice daily may be used instead of dolutegravir, but dolutegravir is preferred due to its once-daily dosing and higher barrier to resistance. PEP patients should receive follow-up with HIV testing at 6 weeks, 4 months, and 12 months. Because initiating PEP is time-sensitive, please keep these medications in stock at your pharmacy. The final component of the prospective drug review is the route of administration. Antiretroviral agents are available in various formulations, including oral tablets, oral liquids, and injectables, so you have options if there are patient-specific requirements that must be considered, such as if the patient has a feeding tube, or dysphagia, or odonophagia. In this case, use a drug information resource to determine if the medication can be crushed or if there is an oral liquid formulation available. In addition to your traditional drug information resources, the National HIV Curriculum, hosted by the University of Washington, is a great free resource with lots of information and clinical trial data regarding the antiretroviral drugs. It also features a modular training course on providing comprehensive HIV care. Next, we will investigate the holistic, patient-centered approach to HIV care. As you enter into practice, you'll find that patients and providers frequently have differing priorities and concerns, and this is true for nearly all disease states, but particularly for HIV. While healthcare providers may focus primarily on getting the patient's HIV infection and general health under control, there may be additional patient-specific concerns and lifestyle factors that compete for your patient's attention, especially in patients who have been newly diagnosed with HIV. These may include denial or difficulty accepting their diagnosis, worry about the stigma associated with HIV and the new label that they may perceive has been placed on them. And because of this, a lot of newly diagnosed patients have a lot of privacy concerns and may not reveal their diagnosis to family or friends. Aspects of the patient's lifestyle, such as sexual orientation, sexual preferences and behaviors, gender identity, and substance use can also come into play. The CDC have some very useful resources on taking a sexual history that can help providers navigate some of these potentially uncomfortable and difficult to discuss topics. Additional factors that may affect patients' engagement in their own care include mental health, socioeconomic status, health literacy level, and the burden of having to take medication every day. To have the best outcomes, it is important to meet the patient where they are. Create a welcoming, judgment-free environment and a safe space for the patient. It is also very important to refrain from using stigmatizing, patronizing language, even if unintentionally. As an example, using the term drug abuse instead of drug use may cause patients to feel judged or ashamed and prevent them from opening up and sharing that information with you. It may seem small, but patients pick up on these kinds of details, which could make the difference between your patient being engaged in care or just shutting down. It is also important to respect the patient's gender identity and use their preferred names and pronouns. If you are unsure of a patient's preferences, you could share that information about yourself and then ask the patient if they feel comfortable sharing that information with you. For example, I might introduce myself to a transgender patient like this. Hi, my name is Nick and I'm one of the pharmacists here in clinic. I use he/him pronouns. Are you comfortable sharing how you would like to be addressed? This simple but profound act can instantly help build rapport and trust with your patient. Additional tactics that should be used to empower patients include motivational interviewing and shared informed decision making. The crux of the holistic patient-centered approach to care can be summarized by the phrase, treat the patient, not the disease. Although it is true that there are specialized aspects of caring for people with HIV, as we saw in the prospective drug review, the general process is the same as any other patient. It's important to not have tunnel vision and focus on only one disease state, because no disease state is truly independent, and vicious cycles and feedback loops could be at play. As an example, let's examine the potential vicious cycle that can occur when someone has both HIV and diabetes. Obviously, HIV is immunocompromising. Patients receive antiretroviral therapy, frequently with integrase inhibitors, which can cause metabolic side effects. As a result, their diabetes is more difficult to control. Well, diabetes itself is also immunocompromising. So now the patient is in an even more immunocompromised state, which worsens patient outcomes. As another example, let's take a look at HIV and substance use. HIV can increase the risk of depression. When patients get depressed, they might turn to substance use. Substance use can negatively affect patients' adherence to antiretroviral therapy. Poor adherence to antiretroviral therapy worsens the patient's HIV control. This, in turn, can lead to even worsening depression and poor patient outcomes. Let's take a closer look at the clinical workup process for people with HIV and how this fits into the holistic patient-centered approach. Although we will be focusing specifically on working at patients with HIV, the overall approach and process that I present is general enough that you can adapt it and use it to work up any patient. It may seem like a lot of information to consider, especially at first, but with time and practice as you progress through your clinical rotations and develop these skills, your process will become more efficient and less time-consuming. The first step is performing a prospective drug review. First, be sure to review the patient's known allergies. Then, identify the patient's current or proposed antiretroviral treatment regimen and determine if it is a complete regimen. Next, use I-escaped CPR to evaluate all of the patient's medications for appropriateness. While reviewing the patient's medications, think about what disease states we can infer from the medications that the patient is taking. Ask yourself, how might these disease states affect the patient's HIV control? Is there anything that could affect adherence, such as an underlying behavioral health concern or substance use disorder? Then zoom out and look at the big picture effect of the medications and disease states on the patient's overall health. Next, assess the patient's virologic control. This is done by quantifying the amount of HIV RNA detected, also known as the viral load, as well as the patient's CD4 panel. Look not only at the numbers themselves, but also at the trends. Determine what stage HIV the patient has. Does the patient have AIDS? Does the regimen appear to be working? If not, do we suspect it to be due to resistance, or is the patient maybe non-adherent? Next, assess for opportunistic infections. Are there any present that require treatment? If not, should OI prophylaxis be initiated or discontinued at this time? A helpful tool to remember these questions are the OI guidelines found at clinicalinfo.hiv.gov. I'll review the most important and frequently encountered opportunistic infection prophylaxis regimens that you should know for the NAPLEX. The first of these is indicated when the absolute CD4 count is below 200 cells per microliter to protect against pneumonia caused by Pneumocystis jirovecii, which is a yeast-like fungus. The preferred prophylaxis regimen for this is cotrimoxazole 800 mg 160 mg by mouth daily. In most cases, this should be continued until the CD4 count has risen and remains above 200 cells per microliter for at least 3 months. For patients who are allergic to cotrimoxazole, dapsone could be used, but there is a small risk of sulfonamide allergy cross-reactivity. In that case, the other option is atovaquone, but this is an unpleasant tasting suspension, and a lot of patients have a hard time tolerating it. When the CD4 count falls to below 100 cells per microliter, prophylaxis is indicated against encephalitis caused by Toxoplasma gondii, which is an intracellular protozoan parasite. The preferred prophylaxis regimen is the same as for PJP, cotrimoxazole 800 mg 160 mg by mouth daily, and again, prophylaxis should continue until the CD4 count has risen to above 200 cells per microliter for at least 3 months. If patients have a sulfonamide allergy, they could use either atovaquone or a regimen containing dapsone plus pyrimethamine plus leucovorin. If the CD4 count is below 50 cells per microliter, there is concern for Mycobacterium avium complex. In this case, the best prophylaxis is a fully suppressive antiretroviral treatment regimen, and prophylaxis with antibiotics is not recommended, except in unique circumstances. The next step in working up patients with HIV is to review guideline-directed routine infectious disease screenings. The first of these is tuberculosis, which is the worldwide leading cause of death in patients with AIDS. Screening for tuberculosis in people with HIV is preferably done with an interferon gamma release assay, or IGRA, such as the QuantiFERON TB Gold. This is because traditional PPD tuberculin skin testing has a lower sensitivity for detecting tuberculosis in immunocompromised patients, who may not have an adequate immune response to tuberculin skin testing, resulting in a missed or delayed diagnosis. People with HIV should be screened for tuberculosis annually. People with HIV are usually also at a higher risk of contracting other sexually transmitted infections, and so routine STI screening is recommended typically every 3 to 6 months, depending on patient-specific risk factors. Gonorrhea and chlamydia screenings should be performed on all at-risk bodily sites, including the pharynx, rectum, vagina, and urine. Unlike urine screenings for urinary tract infection, which should be collected using a clean catch method, urine samples for STI screenings should not be a clean catch, but should include the first voided urine, and ideally be the very first urination of the day after a night's sleep to improve the sensitivity of the test. Patients should also receive routine screening for syphilis, which is another concerning sexually transmitted infection caused by the spirochete Treponema pallidum that can wreak havoc throughout the body if left untreated. Screening and diagnosis are typically performed using an algorithm of 2 tests, rapid plasma reagent, or RPR, and Treponema pallidum particle agglutination, or TPPA. Interpretation of these tests is somewhat complicated, and you will not be expected to interpret them. Screening for other sexually transmitted infections, such as Mycoplasma genitalium, or MGen, are not currently routinely performed, but may be performed if these infections are suspected. The CDC offer a comprehensive STI treatment guide on their website, as well as a free mobile app, which is a great tool for you to have with you on rotation. Next, assess the patient's renal function with a basic or comprehensive metabolic panel. Remember to always calculate Cockcroft-Gault creatinine clearance, which is used for the majority of drug dosing. Don't be tempted to use the eGFR that is typically shown in electronic health records, since this is calculated using the MDRD study equation and is used for staging chronic kidney disease and some drug dosing, such as metformin. Although the eGFR is usually similar to the creatinine clearance, sometimes they can be quite different, so it is important to use the appropriate one. Next, assess the patient's hepatic function, including transaminases and the synthetic liver function tests that we discussed earlier. Also check for the presence of chronic viral hepatitis and treat if indicated. Hepatitis B treatment should be started right away and will require lifelong treatment with 2 agents that are active against hepatitis B. If a patient has hepatitis C, it is best to defer treatment until the patient's HIV is virologically suppressed. And in case you are wondering about hepatitis A, there is no treatment for hepatitis A besides supportive care. The body will clear hepatitis A on its own, typically within 6 months, with no long-term liver damage. In addition to screening for the presence of these infections, also check for the patient's serologies for immunity to hepatitis A and B, and vaccinate them if they are not immune. And in case you are wondering why we don't vaccinate people for hepatitis C, it's because there currently is no hepatitis C vaccine. Next, assess the patient's ASCVD risk, glycemic control, and related chronic disease states. The American College of Cardiology offer a great free ASCVD risk calculator mobile app, which I recommend that you download to have with you on your rotations. HIV increases the risk of ASCVD, but the calculator does not include HIV as a risk factor. Therefore, if you use the calculator for an HIV patient and it tells you that their risk is 6%, for example, you know that their risk is no less than 6% and it is actually higher. Use the results of the calculator, as well as hemoglobin A1C and lipid levels, to determine if any medications, such as statins, antihypertensives, insulin, GLP-1 agonists, etc., should be initiated or their doses optimized. Ask all patients about tobacco use and firmly recommend them to quit. Don't be too pushy, though, if patients are pre-contemplative about quitting, and be sure to use motivational interviewing. If patients are interested in quitting, encourage them and provide them with resources to help them achieve their goal. Ask all patients about their diet and encourage healthy eating habits. The DASH diet and Mediterranean diet have been clinically proven to improve hypertension and reduce ASCVD risk, so recommend these to your patients. Also remember to ask how and when patients take their antiretroviral medications with regard to food, and assess for any drug-food interactions, like the integrase inhibitors with dairy products or ART-specific dietary requirements, such as the 500 kilocalorie meal containing fat and protein that is required for optimal absorption of rilpivirine, since this may not be realistic for homeless patients or those without a stable food supply. Finally, ask about exercise and recommend that patients be active, since the American Heart Association guidelines recommend that adults perform at least 150 minutes of moderate intensity aerobic activity per week to stay healthy. Nutrient deficiencies, bone health and osteoporosis risk, and anemia should also be assessed. Chronic diseases, including HIV and other diseases such as diabetes and chronic kidney disease, as well as some of the drugs used to treat these diseases, can cause nutrient and vitamin deficiencies and adversely affect bone mineral density. Any identified nutrient and vitamin deficiencies should be addressed as part of optimizing health and managing these chronic disease states. There are a few other screenings that are recommended as preventive medicine and health promotion for people with HIV. These include screening for and addressing obstructive lung disease and certain cancer screenings. Mental and behavioral health screenings for anxiety, depression, post-traumatic stress disorder, bipolar disorder, and other neurocognitive disorders are also recommended, since these conditions could negatively affect adherence and lead to worse patient outcomes. Common screening questionnaires for these include the PHQ-2 for depression, the GAD-2 for anxiety, the PC-PTSD-5 for PTSD, and the MMSE to assess general cognitive function. Substance use disorders can also be detrimental to patient health. The substance of choice may vary, but the most harmful and common ones that are seen are ethanol, methamphetamine, and opioids. These substances almost always have a negative effect on adherence and worsen disease progression. They also decrease patients' inhibitions, which can cause patients to get into situations that endanger themselves, such as by getting into fights or walking into traffic, or situations that result in increased transmission of disease, such as anonymous sexual encounters or sharing dirty needles. Common screening questionnaires for substance use include the TAPS and Audit C. Assessing recent healthcare utilization or lack of utilization can provide insight into a patient's overall health and how engaged they are in their own health maintenance. Is the patient keeping their primary care appointments, or are they missing those appointments? Are there any recent unscheduled visits, such as to the emergency department or urgent care clinic? Has the patient been hospitalized recently? Was the purpose of the unscheduled visit or hospitalization HIV related, or was it due to some other reason, such as trauma, substance use, or behavioral health? By monitoring healthcare utilization, you can identify which patients need closer follow-up and provide targeted interventions and resources to the patients who need them most. The last, but certainly not least step of the patient workup process, and not just for HIV patients, but all patients, is immunizations. Assessing a patient's immunization history and making vaccine recommendations is extremely important, and this should be reviewed at every visit. Immunizations are one of humanity's greatest achievements, since it enables us to prevent disease that would otherwise be extremely detrimental to personal and public health. It is much better and easier to prevent a disease now instead of treating it later. This is why recommending and administering vaccines is one of the easiest yet most impactful interventions that pharmacists can make. Correctly interpreting the CDC vaccine schedules to formulate appropriate immunization recommendations is a critical skill that you need to develop. Unfortunately, almost every student and resident I have ever precepted, and even some clinicians I work with, interpret the vaccine schedules incorrectly at first, but once you understand how to interpret them, it really isn't all that difficult. And since the vaccine recommendations can change as new science becomes available, learning to interpret the schedules is much more important than just trying to memorize everything. The CDC vaccine schedules are available online, and surprise, surprise, they have an awesome free mobile app that you should download right now. I'm telling you, one of the best ways to impress your future preceptors is by identifying and recommending a vaccine that a patient needs, especially because vaccines are frequently overlooked. It will instantly show your preceptor that you are on top of it and have done your homework. The CDC have several different vaccine schedules that are tailored to different patients of different age groups or those who have certain medical conditions. For HIV, there are two distinct vaccine schedules that are used, depending on the patient's CD4 count. In addition to the colorful vaccine schedules table that I showed you at the beginning of the presentation, there's a section with notes for special situations for each vaccine listed in the table. These notes are not an optional supplement, but a vital part of the vaccine schedule that should always be reviewed. Failing to consult these notes for special situations or not understanding how to interpret these notes are the two main culprits for making an incorrect immunization recommendation. Included in the vaccine's notes for special situations are a list of any contraindications to receiving the vaccine. In general, live vaccines are contraindicated for people with HIV, with very few exceptions. Under no circumstances should a live vaccine be used in a patient with a CD4 count that is less than 200 cells per microliter. You should also be aware of any vaccine-specific contraindications, such as allergy to a component of the vaccine, like eggs, or a history of Guillain-Barré syndrome. Next, we will take a closer look at how to use the CDC vaccine schedules by walking through a patient case together. For those of you who are familiar with the TV show The Expanse, you will appreciate the references that I make throughout the patient cases in this presentation. For those of you who are not familiar with The Expanse, it's a great show on Amazon Prime Video and you should totally check it out. Amos Burton is a 36-year-old cisgender bisexual male with no significant past medical history except for newly diagnosed acute stage 1 HIV-1 infection. He has no known drug allergies, but he reports that he's allergic to eggs, which give him a rash. His immunization history is unknown, except that he tells you that he got all his shots when he was a baby. Remarkable baseline labs and serologies are shown in the table. Assume that other labs are within normal limits. What immunizations do you recommend for Amos at today's visit? If you haven't downloaded the CDC Vaccine Schedules app to your phone yet, please do so now and use it to follow along with the presentation. I really cannot emphasize enough how important it is to master this skill. Once you have the CDC Vaccine Schedules app pulled up on your phone, tap Adult Conditions and then select HIV infection CD4 count greater than or equal to 200 per cubic millimeter. Let's evaluate each row of the vaccine schedule one by one to determine which vaccines Amos needs. The first row of the table, which is the influenza vaccine, says 1 dose annually. However, remember that we need to review the notes for special situations before we can make our final recommendation. Tap the blue text with the vaccine name to bring up those notes. As I mentioned, in general the flu shot is recommended annually for people with HIV, but not the live vaccine. But what about Amos's egg allergy? The notes tell us that the flu vaccine is safe to give to people with egg allergy who experience hives, so it is safe to give this vaccine to Amos. Let's start making a list of the immunizations that Amos is due for today. As we just discovered, the quadrivalent inactivated influenza vaccine, or IIV, is due, so let's add that to the list. Next on the vaccine schedule is the tetanus shot, the Tdap or TD. The table says 1 dose of Tdap, then either the TD or Tdap booster every 10 years, but let's check the notes before we make our final recommendation. Remember that Amos told you that he got all of his shots as a baby. Because we don't know if Amos received the Tdap at or after age 11, it's probably best to restart the series to ensure complete protection. Even if he did receive the Tdap when he was 11, it will not cause harm to restart the series in this case. The notes tell us the details for the series. 1 dose of Tdap initially, then 1 dose of either TD or Tdap 4 weeks after the initial dose, then 1 dose of TD or Tdap 6 to 12 months after that dose, and then 1 dose of TD or Tdap every 10 years thereafter. Let's add the tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis vaccine, the Tdap, to the list. Next on the vaccine schedule is the measles, mumps, and rubella vaccine, which the table says could be 1 or 2 doses depending on the indication. Let's check the notes for special situations to find out what Amos needs. The notes tell us that HIV patients who are not immune to measles, mumps, or rubella should receive a 2-dose series of the MMR vaccine administered at least 4 weeks apart, but that patients must have a CD4 count greater than or equal to 200 cells per microliter for at least 6 months prior to vaccination. So what should we do for Amos? Well, if we look back at his labs, we got MMR serologies. If you think back to immunology, you'll hopefully remember learning about the antibodies IgM and IgG. Here we can see that we detected IgG antibodies for measles, mumps, and rubella, which means that he is immune to all 3, and so the MMR vaccine is not indicated. Because he's immune, we won't give Amos the MMR vaccine. Next on the list is the varicella vaccine, and the table states 2 doses. As always, let's double check the notes before we make our recommendation. The notes tell us that, for HIV patients who are not immune to the varicella zoster virus, the 2-dose vaccination series may be considered as long as the patient's CD4 count is greater than 200 cells per microliter. Now, you may have noticed the error in your handout. For patients with HIV, the immunization should be given 3 months apart, not 4 to 8 weeks apart. I sincerely apologize for this error, and it just goes to show you how important it is to pay very close attention to all of the details in the notes for special situations. Looking at Amos's varicella serologies, we see that varicella IgG antibodies were detected, which means that Amos is immune to varicella, and so the varicella vaccine is not indicated. Sometimes, the Advisory Committee on Immunization Practices, or ACIP, release new immunization recommendations, and it takes time for these updated recommendations to be incorporated into the CDC Vaccine Schedules document and mobile app. For this reason, you should routinely monitor the ACIP and CDC websites for updated immunization recommendations that have not made their way into the app just yet. This is the case for the zoster recombinant adjuvanted vaccine, or RZV, which, as of October 20, 2021, the ACIP now recommend for all patients aged 19 and older who have HIV. This 2-dose series may be given regardless of prior history of chickenpox, shingles, or vaccination with the zoster live attenuated vaccine, which is no longer marketed. However, before the RZV series can be initiated, patients must have completed the varicella primary vaccine series or have documented immunity to varicella. Vaccination with RZV should be deferred in patients who are currently experiencing an acute herpes zoster or shingles episode. For our patient Amos, he is immune to varicella and over the age of 18, so he is due for the RZV today. Let's add the zoster recombinant adjuvanted vaccine, or RZV, to Amos's list. Next up on the list is the human papillomavirus vaccine. The table says 3 doses through age 26 years, but let's check the notes to be sure. The notes clarify that for patients with HIV, the 3-dose series should be completed regardless of the age at initial vaccination. Even though Amos is over age 26, he still needs a dose of HPV vaccine today. Let's add the human papillomavirus 9-valent recombinant vaccine, or HPV, to Amos's list. Next up in the table are the pneumococcal vaccines, the PCV13 and the PPSV23. Like the zoster vaccine, ACIP released updated pneumococcal immunization recommendations for the new PCV15 and PCV20 vaccines, but these recommendations have not yet made their way into the vaccine schedules documents or app. The new guidelines recommend that all people with HIV age 19 and older who have never received the PCV13 either receive one dose of PCV20 or one dose of PCV15 followed by one dose of PPSV23 at least 8 weeks later. The data are better for the PCV20 and it's fewer shots, so let's recommend that one for Amos today. For patients who have previously received the PCV13, the new guidelines recommend sticking with the originally published pneumococcal vaccine series for people with HIV, which is one dose of PCV13 initially, then a dose of PPSV23 at least 8 weeks later, followed by a dose of PPSV23 at least 5 years after that, and then a final dose of PPSV23 at least 5 years after the previous dose upon turning 65 years of age. Let's add the pneumococcal 20-valent conjugate vaccine, or PCV20, to Amos's list. Next in the table are the hepatitis vaccines. The notes recommend that people with HIV be vaccinated against hepatitis A. Although the notes state that either the 2-dose Hep A vaccine or the 3-dose Hep A Hep B combination vaccine may be used, I will say that the 2-dose Hep A series is now the preferred immunization series for these patients. Looking at Amos's serologies, anti-hepatitis A virus IgM antibodies were not detected, but anti-hepatitis A virus IgG antibodies were detected. This means that Amos is immune to hepatitis A, either from a prior immunization or from a prior natural infection. Patients with HIV should also be vaccinated against hepatitis B. The notes list several vaccine options here, but the 2-dose HEPLISAV-B is now the preferred vaccine due to its markedly superior efficacy, and this is why the hepatitis A standalone vaccine is preferred, so that we can give the standalone HEPLISAV-B vaccine, which offers better protection against hepatitis B than the Hep A Hep B combination vaccine. Looking at Amos's serologies, we see that the hepatitis B surface antigen is not detected, and neither is the anti-hepatitis B core IgG antibody. This means that Amos does not have an acute or chronic hepatitis B infection, and has never been infected with hepatitis B in the past. However, the anti-hepatitis B surface IgG antibody is detected, and that means that Amos is immune to hepatitis B due to a prior immunization. Although there is no vaccine available for hepatitis C, looking at Amos's serologies, we see that anti-hepatitis C IgG antibody was detected, but no hepatitis C RNA was detected. This means that Amos does not currently have hepatitis C, but he had it in the past and spontaneously cured the disease on his own without any treatment, which happens in about 30% of hepatitis C cases. Unfortunately, because the hepatitis C virus changes during infection, being exposed to hepatitis C does not confer immunity and will not protect you from a future reinfection. Even though Amos's serologies show that anti-hepatitis C IgG antibodies are detected, he is not immune to hepatitis C. No hepatitis vaccines are due for Amos today. Next are the meningococcal vaccines, MenACWY and MenB. Let's take a look at the notes. The notes tell us that a 2-dose initial series of MenACWY is recommended for patients with HIV, followed by a booster every 5 years, so Amos is due for a dose of MenACWY today. MenB is only indicated if the patient has an additional risk factor, which Amos does not have. Let's add the meningococcal ACWY polysaccharide conjugate vaccine to Amos's list. The last vaccine listed in the table is for Haemophilus influenzae type B, which the key indicates is recommended for adults with a specific risk factor. So let's take a look at the notes. Amos does not have either of the risk factors listed in the notes, so this vaccine is not indicated. Here's the list of vaccines that we've recommended for Amos so far. We're almost done, but there is one more vaccine that we still need to consider that has not yet been integrated into the CDC vaccine schedule document or app yet. Any guesses what it might be? If you guessed COVID-19, you are correct. The ACIP and CDC recommend a 2-dose mRNA primary series for all patients with HIV. Either Moderna or Pfizer-BioNTech are acceptable mRNA vaccines. Patients who initially receive the Janssen vaccine instead of an mRNA vaccine should receive a dose of either mRNA or Janssen, but mRNA is preferred. For patients not on antiretroviral therapy or with a CD4 count less than 200 cells per microliter, either at the present time or at the time of their initial vaccination, an additional supplemental third dose of mRNA vaccine is recommended. A booster dose of mRNA vaccine, which is different to the additional supplemental primary series dose, is recommended for all people with HIV, and this dose should be given 5 months after completing the primary series. Mixing and matching booster doses is allowed and may even be beneficial. For example, if the patient received a 3-dose primary series of Pfizer-BioNTech, a booster dose of Moderna should be given. For our patient Amos, he is due for 1 dose of mRNA vaccine today, followed by 1 dose of mRNA vaccine either 21 or 28 days after that, depending on which mRNA vaccine is being used for his primary series. Because he is not currently on antiretroviral therapy at the time of this initial vaccination, Amos should receive an additional supplemental third dose of mRNA vaccine at least 28 days after the previous dose as part of his primary series. Finally, Amos will be due for a booster dose of the other mRNA vaccine 5 months after that. Let's add the COVID-19 mRNA vaccine to Amos's list of immunizations that are due today. And with that, we have finished our immunization recommendations for Amos. And yes, all of these vaccines could safely be given at the same time, but usually patients don't like getting that many shots at once, so we could prioritize them and space them out. Finally, let's put together everything we've learned by practicing evaluating antiretroviral therapy with some patient cases. Before we get into the cases, however, I wanted to discuss which initial antiretroviral treatment regimens are recommended for most patients, and thankfully there are only a few, which should make studying for the NAPLEX a little bit easier. The ARV guidelines, located at clinicalinfo.hiv.gov, are a helpful resource. Bictegravir, emtricitabine, tenofovir alafenamide, which is commercially available as Biktarvy, is a great initial treatment option for many patients, since genotypic resistance testing is not required before initiation, and it is a once-daily single-tablet regimen. Biktarvy can be safely used in patients with creatinine clearance above 30 milliliters per minute without dose adjustment. However, it should not be initiated in pregnant patients because it has not yet been adequately studied in pregnancy. Abacavir, dolutegravir, lamivudine, which is commercially available as the once-daily single-tablet regimen Triumec, is another guideline-recommended initial treatment option, but patients must be HLA-B*5701 negative before starting it. Triumec is an acceptable option for pregnant patients. The next initial antiretroviral treatment option is the combination of dolutegravir plus either emtricitabine or lamivudine plus either tenofovir alafenamide or tenofovir disoproxil fumarate. Most commonly, this will be the 2-tablet combination of Tivicay plus either Descovy or Truvada, but in the case of renal impairment, the component drugs could be dose adjusted and given separately, and lamivudine could be used instead of emtricitabine. Dolutegravir plus either Descovy or Truvada remains a good initial ART regimen to start for most patients, since HIV genotypic resistance testing is not required before initiation, and these agents are safe to use in pregnancy. The final initial antiretroviral therapy option is dolutegravir lamivudine, which is commercially available as the once-daily single-tablet regimen Dovato. However, Dovato has some requirements that must be met before it can be considered. First, the patient must have HIV genotypic resistance testing before initiation. Second, the patient must have a viral load less than 500,000 copies per milliliter. And third, the patient must be hepatitis B negative. So back to our patient, Amos. We got some additional labs back. Based on the information, which initial ART regimen would be preferred? Please pause the video, write down your answer, and then restart the video when you are ready to hear the correct answer. The correct answer is bictegravir, emtricitabine, tenofovir alafenamide, or Biktarvy. Did you get it right? Let's take a look at why. Triamec is listed as one of the guideline recommended initial antiretroviral treatment regimens. However, the patient tested positive for HLA-B*5701, which means that abacavir is contraindicated, eliminating Triamec as a potential treatment option. The patient's GenoSure Prime HIV genotypic resistance testing shows mutations that cause resistance to the non-nucleoside reverse transcriptase inhibitors. Since Odefsey and Delstrigo contain the NNRTIs rilpivirine and doravirine, respectively, both of those choices are automatically eliminated. Additionally, NNRTI-containing regimens are not guideline-recommended initial ART regimens, which would make them not preferred even if the genotypic testing did not show NNRTI resistance. The only remaining choice is Biktarvy, which is a guideline-recommended initial antiretroviral treatment regimen for most patients, with the exception of pregnant patients. For our next case, we have Kamina Drummer, who is a 34-year-old cisgender pansexual female who presents to your community pharmacy with the prescription shown. What is the likely indication for this prescription? Please pause the video, write down your answer, and then restart the video when you are ready to hear the correct answer. First, let's list all the possible indications for antiretroviral therapy, and then we can use the process of elimination. The possible indications are HIV treatment, HIV pre-exposure prophylaxis, or HIV post-exposure prophylaxis. This prescription is for Truvada, which is emtricitabine tenofovir disoproxil fumarate. Truvada alone is not a complete regimen for the purposes of HIV treatment, so we can eliminate that as a possible answer. The prescription is written for quantity number 30 with 11 refills. HIV post-exposure prophylaxis uses a quantity number 28 with no refills, so we can eliminate that as a possible answer as well. The remaining indication, HIV pre-exposure prophylaxis, or PrEP, is the correct answer. What information do we need to confirm before the prescription can be filled? Please pause the video, write down your answer, and then restart the video when you are ready to hear the correct answer. There are some requirements that must be met before PrEP can be initiated. First, we must confirm that the patient has a documented negative HIV test within 1 week of starting PrEP. Second, we must confirm the patient's hepatitis B status, since Truvada has a black box warning that stopping Truvada in patients with hepatitis B can cause a hepatitis B flare and kill your patient within 6 months due to fulminant liver failure. Dr. Okoye confirms the patient's HIV test was negative today, July 21st, and that the patient is immune to hepatitis B. What changes should be made to the prescription? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. Since repeat HIV screening with a documented negative test result is required every 3 months, change the prescription from 11 refills to 2 refills, and advise the patient of the HIV testing requirements while on PrEP. You should make sure that the SIG says, take 1 tablet by mouth daily for PrEP, next test due 10/21. This way, if the patient doesn't pick up a refill 1 month, the date will prompt you that you should not fill the prescription after the next test due date, even if there are refills remaining. The patient tells you that she would prefer not to have to take a pill every day for PrEP and asks what other options are available. What do you tell her? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. Apretude, or cabotegravir extended-release injectable suspension, is a once every other month injection for PrEP. Please note that on-demand PrEP with the 2-1-1 oral dosing of Truvada is not an option for cisgender women and is not recommended by CDC in general. Our next patient case is Christian Avasarala, a 67-year-old cisgender heterosexual female who presents to your clinic to establish care. She reports that she has been on the same regimen for many years and is hoping to streamline it to decrease the number of pills that she has to take every day. Her current labs are shown, and her current medications include raltegravir 400 mg by mouth twice daily, Epsicom, or abacavir lamivudine 600 mg 300 mg by mouth once daily, and entecavir 0.25 mg by mouth once daily. Which proposed streamline regimen would not be appropriate? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. The correct answer is dolutegravir lamivudine, or Dovato. Looking at the patient's labs, we see that the patient has an undetectable viral load and strong immune system function. The patient is negative for HLA-B star 5701, which is good because they've been taking Abacavir, and she also has some renal impairment with a creatinine clearance of 45 milliliters per minute. We also have some hepatitis B serologies. The hepatitis B surface antigen is positive, the anti-hepatitis B core IgG antibody is also positive, and the anti-hepatitis B surface IgG antibody is negative. These serologies indicate a chronic hepatitis B infection. Another indication that the patient has a chronic hepatitis B infection is the fact that she's taking entecavir. With that in mind, we need to check if the proposed regimens are appropriate for someone with renal impairment and chronic hepatitis B. Remember that hepatitis B requires lifelong treatment with two agents that are active against hepatitis B. Biktarvy, the combination of dolutegravir plus Descovy, and Genvoya all contain emtricitabine and tenofovir alafenamide, which fulfill the requirement for two agents that are active against hepatitis B. Additionally, these three options are safe to use in patients with a creatinine clearance of 45 milliliters per minute. The final option, Dovato, only contains one agent that is active against hepatitis B, lamivudine. This means that Dovato is not an appropriate treatment option for this patient and therefore the correct answer. Our next case is patient James Holden, who is a 40-year-old cisgender heterosexual male who was referred to your clinic after being diagnosed with chronic HIV-1 infection. His baseline viral load is 4 million copies per milliliter, and his baseline CD4 panel shows 45 cells per microliter, 8%. What stage HIV does this patient have? Please pause the video, write down your answer, and then restart the video when you are ready to hear the correct answer. With an absolute CD4 count of 45 cells per microliter, this patient is well below the 200 cells per microliter cutoff, indicating that this patient has stage 3 HIV and AIDS. Which initial treatment regimen is most appropriate for rapid start ART in this patient before any additional labs are back? Please pause the video, write down your answer, and then restart the video when you are ready to hear the correct answer. The correct answer is Biktarvy, or bictegravir emtricitabine tenofovir alafenamide. The guidelines have specific recommendations for initial antiretroviral therapy in most patients. The first choice, dolutegravir rilpivirine, commercially available as Juluca, is not one of those recommended regimens. Additionally, Juluca may only be used when switching regimens in patients who are already on another antiretroviral treatment regimen and have an undetectable viral load. Clearly not this patient. The next option, Abacavir dolutegravir lamivudine, commercially available as Triumec, is one of the recommended initial antiretroviral treatment regimens. However, patients must undergo HLA-B star 5701 screening and have a negative result before Triumec can be initiated. Atripla, which is efavirenz, emtricitabine, tenofovir disoproxil fumarate, is not a guideline-recommended initial therapy for most patients. The remaining choice, Biktarvy, is specifically listed in the guidelines as a recommended initial treatment option for most patients and can be used before genotypic resistance testing results are back. In addition to ART, what OI prophylaxis should also be started at this time? Assume that the patient has no known drug allergies and no history of AIDS-defining illness. Please pause the video, write down your answer, and then restart the video when you are ready to hear the correct answer. The correct answer is cotrimoxazole 800 mg, 160 mg by mouth once daily. With a CD4 count of 45 cells per microliter, an opportunistic infection prophylaxis regimen that will protect against Pneumocystis jirovecii and Toxoplasma gondii is indicated, but prophylaxis against Mycobacterium avium complex with antibiotics is not indicated, since the patient is being started on antiretroviral therapy. The patient has no drug allergies. Cotrimoxazole 800 mg, 160 mg by mouth once daily will cover both PJP and Toxoplasma gondii, and therefore is the correct answer. Cotrimoxazole plus azithromycin is incorrect because prophylaxis against Mycobacterium avium complex with antibiotics is inappropriate for this patient. Although dapsone alone would provide appropriate prophylaxis against PJP, it must be combined with pyrimethamine and leucovorin to provide adequate protection against Toxoplasma gondii, making that answer incorrect. Fluconazole is an antifungal agent that can be used to treat thrush, but routine prophylaxis against thrush is not recommended, and fluconazole would not offer protection against PJP or Toxoplasma gondii, making it an incorrect answer. James presents to his 3-month follow-up appointment. He reports that he has been adherent to the treatment that you recommended. His updated labs show a viral load of 20,000 copies per milliliter and a CD4 count of 225 cells per microliter. What therapy changes do you recommend today? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. The correct answer is that none of the above changes should be made today. Although you may be tempted to discontinue cotrimoxazole, since the CD4 count is greater than 200 cells per microliter, and this is the patient's 3-month follow-up, remember that the CD4 count must be greater than 200 for at least 3 months. Because this is the first CD4 count that we have measured that is above 200 for this patient, the 3-month timer starts now. If the patient's CD4 count remains above 200 at a follow-up appointment 3 months from now, then the cotrimoxazole could be discontinued at that time. Adding fostemsavir to the current regimen is not appropriate, since this agent is reserved for highly treatment-experienced patients with multiple drug resistance mutations who are unable to otherwise achieve viral suppression. Although the patient's viral load is not yet undetectable, it has dropped precipitously from its initial viral load of 4 million. It can take between 3 to 6 months or even longer for newly diagnosed patients' viral loads to become undetectable, particularly when they have high-level viremia at baseline, like this patient did. Although we may consider switching the patient to Cabenuva in the future, patients must have an undetectable viral load before that change can be made, making that choice incorrect as well. 1 year later, James presents for a follow-up appointment. He is grateful for all the help you've provided over the past year and states that he feels much better. His updated labs now show an undetectable viral load and a CD4 count of 368, 23%. What stage HIV does the patient have now? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. Because his CD4 count falls between 200 and 500, the patient's HIV can now be classified as stage 2. As a follow-up question, does this patient still have AIDS? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. The answer is yes. Once a patient develops AIDS, they are always considered to have AIDS. Our next patient case is Naomi Nagata, a 36-year-old cisgender heterosexual female who presents to your community pharmacy with the prescription shown. She states that she was sexually assaulted by Marco Inaros. Is this prescription complete, safe, and effective? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. The answer is no. Descovy cannot be used for PEP. You must use Truvada. You contact Dr. Okoye, who thanks you for your recommendation and changes the prescription. What other information should we confirm before filling this prescription? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. Confirm the timing of the exposure, since PEP must be started within 72 hours of exposure. Also, ensure appropriate follow-up is in place at 6 weeks, 4 months, and 12 months. And finally, determine the patient's baseline HIV and hepatitis B status, since patients who are HIV positive would require HIV treatment, not post-exposure prophylaxis, and patients who have hepatitis B would also require lifelong treatment, and when Truvada is stopped at the end of the 28 days of PEP, the patient would be at risk of developing a hepatitis B flare, which could kill the patient within 6 months due to fulminant liver failure. Clarissa Mao is the subject of our next case. She's a 38-year-old cisgender pansexual female who has been taking abacavir, dolutegravir, lamivudine for her chronic HIV-1 infection for the past several years. Today, she admits that she's worried about her heart health, since she recently learned that her illegal body mods could increase her risk of heart attack. Her current labs show an undetectable viral load, strong immune function, and immunity to hepatitis B due to vaccination. You would like to modify her ART regimen to decrease her cardiovascular disease risk. What do you recommend? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. In this case, it makes sense to remove the abacavir component of the patient's regimen, since abacavir can increase the risk of cardiovascular disease. The easiest way to accomplish this is by switching Triumec to Dovato. Our final case is that of Roberta Draper, a 27-year-old cisgender heterosexual female who recently transferred to your Martian Marine Corps outpost and presents to clinic to establish care. Her chronic HIV-1 infection has been virologically suppressed with Biktarvy, bictegravir, emtricitabine, tenofovir, elafenamide. But she would like to know if there is any way she can stop taking pills every day while she's on deployment. What do you recommend? Please pause the video, write down your answer, and then restart the video when you're ready to hear the correct answer. This patient would be a candidate for Cabenuva, which are co-packaged but separate long-acting injections of cabotegravir and relpivirine that are administered once monthly in clinic. Before starting Cabenuva, the patient must complete a 28-day oral lead-in with cabotegravir and relpivirine tablets, which are commercially available as Vocabria and Edurant, respectively. Here are my references to the guidelines and resources used throughout the presentation. Thank you for your attention during the presentation. I hope that it has provided you with some helpful clinical insights into not only HIV care, but also clinical practice in general, and that you will be able to use these tools and resources as you move forward throughout pharmacy school and your future rotations. If you have any questions about the presentation, GIMC's API or residency program, or anything else, please reach out to your professor and she can provide you with my email. She's also going to be giving you a link to a survey that I've created so that I can get your feedback about this presentation, and I thank you in advance for taking the time to complete the survey. Your feedback is truly important to me, and I promise I will read every single one.